Welcome to Healing with Her, the podcast where women in medicine share bold and honest conversations from the front lines of healthcare. Step into the world of Black women medical professionals as they unpack the power of healing, the weight of care, and the beauty of showing up whole.
Welcome to Healing with Her, the podcast where women in medicine share bold, honest, and healing conversations from the front lines of healthcare. I'm your host, Dr. Sosa, and I'm thrilled you're here. Whether you're a healthcare professional, someone passionate about wellness, or someone who's looking to gain more knowledge about your own health, you'll find stories here that resonate, educate, and inspire. This podcast was born from a shared truth. Healing isn't just about medicine. It's about connection, listening, and leadership. And who better to lead those conversations than women physicians? The information shared on Healing with Her is intended for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your physician or other qualified medical professional with any questions you may have regarding your health. The views expressed by the hosts and guests are their own and do not necessarily reflect those of their institutions or employers. So today we have the pleasure of having Dr. Kimberly Wooten here with us. Dr. Wooten, would you like to introduce yourself to us and tell us what you do?
Absolutely. I am a head and neck surgical oncologist, and so that essentially means that I work with patients that have thyroid diseases as well as head and neck diseases, including oncological diseases, cancers of the skin, throat, tongue, mouth, as well as cancers of endocrine organs like the thyroid and parathyroid.
Very nice. So, woman of many talents, huh? So tell us, you mentioned the thyroid a couple of times, and today we'll try to focus on the thyroid. Tell us, what is the thyroid? What does it do?
That's a great question. So the thyroid is a butterfly-shaped organ that essentially sits just above the clavicle, also known as the collarbone. And so if you kind of feel in yourself, there's a notch in between the collarbone, and it sits about 2 finger widths above that. In men, it's easier to find because it sits just beneath the Adam's apple. So what it does, it's kind of a master of none, jack of all trades kind of organ. I kind of think of it like an wireless organ in a way. So if we're thinking about it technologically, it does a lot of things for all areas of the body. So it's a part of the endocrine system, which of course sends hormones throughout from the brain to areas of the body to control different types of tissues. And unfortunately, the thyroid has been implicated in a lot of symptoms. So the thyroid can control our weight levels, so weight gain, our energy levels, our sleep cycle. In women, it affects sexual function, and hormones can affect fertility. So there's all sorts of areas of the body that the thyroid contributes to.
Yeah, I see what you're saying. It really just kind of has its hands in every other organ system and could affect so much. So what symptoms would somebody be experiencing that would prompt them to get thyroid care?
Yeah, and that's a slew of symptoms. And unfortunately, they tend to be very common and nonspecific. So one of the biggest symptoms that I oftentimes see is going to be weight gain. And then another is problem sleeping or significant fatigue or tiredness. There are other symptoms such as hair loss, and I think that's super important in women, especially African American women and women of color, because that's a big source of hair loss that we can contribute to a hormonal cause. Problems with their menstruation, their cycles. Also issues with skin, having dry skin, having rashes, things like that if it's very severe. But there's a slew of symptoms. So there's not one particular symptom. It's just kind of them together. I think probably the biggest would be fatigue and weight gain in terms of really hitting the nail on the head to seeking additional treatment.
So are you implying that anyone who notices that they're gaining weight should definitely have their thyroid checked?
So I think there's a number of reasons why people can gain weight. Obviously, in addition to monitoring their diet and making sure they have a typical exercise routine, it's super important. But if you're noticing that you're starting to gain weight and it's out of norm for you, or it's a significant amount in a short period of time, I would certainly start with having typical thyroid labs, just because if it's a normal level, then it lets you know that something else is probably the cause. But if it's abnormal, then you can do further workup.
Okay.
Just a question, because I have a lot of patients who said, well, they checked that already. What would you recommend lab-wise if you were going to just for screening for checking your thyroid?
Yeah, I think in general, I would always start with a TSH, a T3, and a T4. And those are the basic labs that really give us a global view of what's going on within the thyroid. And if that's abnormal, we can certainly extend that to other thyroid-specific labs, such as antibodies. But I would probably start with that.
Okay.
And so I've heard about thyroid nodules. Tell me what those are. Help our audience understand what those are.
Absolutely. So thyroid nodules are portions of the thyroid gland that are, it's kind of like a mass or a tumor without meaning cancer. And it's quite common. It's about 50 to 60% of adults are going to have thyroid nodules. The vast majority of them don't even know that they have them. And for most patients, there's no clinical significance, meaning they're not going to have a problem later on in life. But the reason why thyroid nodules become important is because sometimes they can be hyperactive or hypoactive, and they can certainly contribute to problems with the thyroid long term. Additionally, we do see that there are association with thyroid cancer based on the appearance of thyroid nodules on ultrasound. So they can certainly be the cause for additional workup. So if you are found to have thyroid nodules, it is important to see a specialist for additional information and determine if further workup should be done.
Is it the kind of thing that should be followed regularly also? So say you come in, you have that workup done. Should I get my thyroid checked every year as a result?
Yeah, so typically above the age of 18, that should be standard in typical workup for primary care doctors. So they should be looking at thyroid function at least once every few years once you're an adult. Now, it's not something that many physicians do every single year, especially if patients don't exhibit any symptoms or complaining of any symptoms and have had a prior normal thyroid function. But in general, it should be a part of just general screening, and the symptoms should be evaluated at any physical at your primary care doctor's office. So they should be talking about weight gain, how you're sleeping, energy levels, and things like that, just to see in terms of a review of systems, is there something that would equate to further workup later down the line.
Now, if they're found to have thyroid nodules, how often would you say they need to be followed up in terms of size and what they look like?
Yeah, and that's a great question. So the standard with thyroid nodules, of course, would start with an ultrasound. So patients would come in and get an ultrasound, and based on the appearance of the nodules on the ultrasound, we would then determine really if they need to be followed at all, if they need a biopsy, or if there's anything else that we should be doing at that point. Now, once it is above a certain standard size, so for instance, if it's a 1 centimeter thyroid nodule, typically we would not recommend any form of biopsy or even additional workup. But radiologists now have a scoring system, so they give these thyroid nodules a number that let us know how long we should follow them and if we should biopsy them once they reach a certain size. And the reason why that is important is because not every thyroid nodule needs to be biopsied. And it's because they look a certain way on ultrasound, and if they look completely benign, nothing to do. But if they have concerning characteristics such as the shape, the size, for instance, if it is a smooth margin around the nodule, not really much of concern. But sometimes if the margin is irregular, that is more concerning. Or if there's echogenic foci, also known as calcifications within the thyroid nodule itself, that increases the risk of there being a malignancy. And those should have further, longer workup. And once they reach a certain size, should be biopsied.
I often encounter patients when they hear the word biopsy, they get very afraid. Do you mind sharing what a biopsy would be like, what that experience is like?
Yeah, absolutely. So generally, that entails use of an ultrasound to identify and find the nodule of concern. And then the skin will be numbed up with a numbing agent. So that does require a needle stick to numb up the skin where the biopsy will be performed. And then once the skin is numb, an additional needle, will be placed in the skin. Hopefully it should be numb at this point. And pieces of the thyroid or the nodule should be removed. Sometimes patients can experience bruising, a little bit of soreness at the site, and swelling. That's not uncommon and completely a part of what we would expect after this type of procedure. But generally it is done when patients are awake. So you will be awake. It's not something done under general anesthesia. But that's essentially what the thyroid nodule biopsy would entail.
Thanks for clarifying that. So we talked about some benign issues you might encounter with the thyroid. You have nodules. You may have a hypoactive or hyperactive thyroid. Let's move into the realm of thyroid cancer. And can you tell us a bit more about the types of thyroid cancers that you encounter in your practice?
Yeah, absolutely. So thyroid cancer is actually fairly common what we see in this area when it comes to, and obviously I'm a specialist, so I get selective patients. So the vast majority of them either have thyroid cancer or have nodules that are concerning for thyroid cancer. And there's 4 main types of thyroid cancer. The most common is called papillary thyroid cancer. That's about 80 to 85% of thyroid cancers. In general, it's very indolent, meaning slow growing. And typically, although I would never say this about a cancer, but it's oftentimes described as, quote, the good cancer to have, because it's less likely to spread to other areas of the body. And in general, patients can live a normal life after appropriate management of the thyroid cancer. So in general, this is a type of cancer that is less aggressive. The second type is follicular thyroid cancer, and that's a little bit less common. It's about 10% of all thyroid cancers. And that one has a tendency to be a little bit more aggressive, meaning that it can spread to lymph nodes and it can also spread to other areas in the body. Medullary thyroid cancer is probably in the news more frequently now because of the weight loss medications that we oftentimes use. Yeah. But this is a particular type of thyroid cancer that is genetically induced and oftentimes has a hereditary component. And that's called medullary thyroid cancer, and it is associated with a condition called multiple endocrine neoplasia, type 2. So patients who have a family history of this condition should certainly be screened for medullary thyroid cancer. But again, it is treated quite easily. Surgery and additional adjuvant treatment is also part of that management. But we will talk about that a little bit later on in the podcast, I think. But it is something that we should be aware of, especially because of some of the new medications that we have. And then the last, and I think the most concerning, is called anaplastic thyroid cancer. This is a very aggressive cancer that has a very high mortality. There are some treatments that include chemotherapy and immunotherapy for certain patients, but that fortunately only comprises about 2% of thyroid cancer.
Do you notice any of these cancers tending to be more prevalent in certain communities or certain groups at all? We had our conversation about fibroids recently, and we talked about how there's a higher rate of fibroids in African-American women as opposed to other groups. Do you notice any trends like that with thyroid cancer?
Well, the main trends with thyroid cancer is not per se the percentage of thyroid cancer, but in general, African-Americans tend to have more complications associated with the treatment and management of thyroid cancer. It's unclear why, if it's just lack of attention from physicians, if it's not really having an advocate for themselves, or is it social factors that create barriers to care? I think all of those probably play into that, but we do see for people of color, specifically African Americans, that there is a higher incidence of some complications associated with the treatment of thyroid cancer.
Good to know. You had mentioned adjuvant therapy. Do you mind clarifying what that means? Is that chemotherapy? Is that radiation?
So that really depends on the type of thyroid cancer that we're talking about. The primary treatment for any thyroid cancer is going to be surgical, and that means making an incision across the neck and removing the thyroid, as well as any associated lymph nodes. However, in some patients that have more aggressive forms of thyroid cancer, an additional treatment called radioactive iodine may be employed. Chemotherapy and radiation is generally reserved for patients that have metastatic thyroid cancer or the more aggressive type, such as anaplastic.
Gotcha. Are there any major risks with thyroid surgery?
Absolutely, and I think that's a super important question to ask your surgeon and to ask your primary care doctor, especially once the diagnosis of thyroid cancer has already been made. So the procedure itself is requires an incision, of course, in the front of your neck because that's where the thyroid is located. And then the thyroid sits in between very important organs. So it sits next to some of the blood vessels that go to our brain, and it also sits right next to a nerve that goes to our voice box and controls our voice. And so those are probably some of the bigger risks of the procedure. Injury to that nerve that can lead to hoarseness, sometimes problem swallowing, and sometimes shortness of breath and problems breathing. There is also a small gland called the parathyroid gland that sits right next to the thyroid. And because they share the same blood supply, sometimes just by removing the thyroid itself, those organs won't work. And because they help to regulate calcium in the body, some patients after thyroid surgery will need to be on a calcium supplementation. And in about 1% of patients, that can be lifelong. As for some other risks, such as bleeding, need for more surgery, that, of course, is a risk, as with any particular type of surgery. But those are probably the top few risks that we see and should certainly be counseled on before any movement toward surgical treatment.
Is this the type of surgery where someone needs to spend the night at the hospital?
Generally, if it's half of the thyroid, we can sometimes send you home the same day. I typically, in my practice, will always keep my patients overnight just to make sure that any postoperative complications are dealt with acutely, and just to make sure that they're ready to go home and they feel good enough, and there's nothing else that we need to do in between before seeing them again in postoperative for their postoperative visit.
You had mentioned in terms of medullary that there are some genetic components. Do you recommend patients who do have thyroid cancer in their families to have any genetic testing done?
I think that's a great question. So specifically for MEN2, there tends to be other symptoms that generally present themselves around the same time, if not sooner. Oftentimes, because MEN2 has such a specific group of symptoms, patients will oftentimes present with increased calcium as one of their first symptoms because they oftentimes are associated with hyperparathyroidism, which causes hypercalcemia. But if you have, say, a grandmother that, say, had a certain type of adrenal tumor called a pheochromocytoma, which can happen on its own, but if it's something that, let's say, grandma had it and then maybe mom has hypercalcemia, those are the things to kind of prompt, maybe I should get further workup, and asking your physician for standard blood work to rule that in or out, which is relatively inexpensive and can certainly rule the condition itself in or out.
How about non-surgical treatments? Are those a thing?
So yeah, that's, I think, of course, everything is minimally invasive now. So now we're talking about operating with a robot. We're talking about operating laparoscopically. So there's certainly areas in which thyroid cancer can be treated in other ways. I, at this point, can't really advocate for that or say that that's really the standard of care. But for very, very small thyroid cancers, sometimes radioactive iodine frequency can be used, and I guess minimally invasive surgery. So minimally invasive surgery for thyroid surgery is, instead of taking out the whole thyroid, taking out half of the thyroid. If there's only one small area of thyroid cancer, then that's really been what the standard of care has evolved into. Unfortunately, surgery still is the primary way to treat thyroid cancer because it can always come back. Unfortunately, there are patients who 20 years after they've had thyroid cancer completely treated can sometimes have it represent itself. And so that's why we tend to follow patients lifelong, just to follow for thyroid cancer, because it can recur at any point.
How about natural remedies, special diets?
Yeah, I think that's a harder question too, but I get asked this often, and particularly with thyroid nodules, which, again, thyroid cancer can originate from thyroid nodules, but most nodules will be benign. So let's say you have a large thyroid nodule that's been biopsied, does not show any evidence of cancer. There are certain managements, such as radiofrequency ablation, which can certainly shrink those tumors. I also get asked a lot of questions about thyroid medication. Thyroid medication, in terms of taking levothyroxine, hasn't necessarily been shown to, let's say, reverse a thyroid cancer. But I think making sure that you have ideal thyroid function can help patients with thyroid goiters and larger nodules kind of stay the same size. Because this is kind of like a whole, it's like I mentioned before, it's a big endocrine system. So everything is affected by everything else. So if you don't have enough thyroid hormone in your body, your brain thinks that your thyroid is not functioning. So it's going to try to get the thyroid to function more. And by doing so, the thyroid will get larger. And so I think making sure that you have a normal thyroid function is super important. So if you are hypothyroid, you should definitely be on thyroid medication to supplement those hormones that your body isn't making. If you are hyperthyroid, then it's also important to follow that closely and see an endocrinologist to ensure that you don't need to be on a medication that can even out your thyroid function.
Okay. All right. Lots of really good information here. And I feel like these conversations always has my mind going, and I learn so much myself. So I really hope our audience learns a lot too. Let's talk about the big thing everybody talks about now. Everybody, GLP-1s are all in the media. The celebrities are using it. Just recently, Serena Williams came out speaking about the fact that she's using a GLP-1. As a head and neck surgeon who understands the risks of using these and who sees thyroid cancer, what's your take on it?
So I think that's a great question, and I think it's something that we're going to see a lot more of in the next 2 to 5 years. So we used to, at least in my practice, I used to tell any patient that had thyroid nodules or history of thyroid cancer that they could not be on GLP-1 at all. But looking at the research and the data, we do know that it is associated with a specific type of thyroid cancer, and that is medullary, which fortunately is not very common. So that opens up the door to a lot of patients who otherwise would not have the opportunity to use this to manage their weight and their diabetes. So I basically say this: as long as you don't have any known history of MEN, you have not been diagnosed with it, you have not been treated with it, and there's no family history, it's relatively safe to use within within the conversation between you and your primary care doctor or the prescriber. But I do think that in patients that have thyroid nodules and have a history of thyroid cancer in general, they certainly should be followed up. So they should have ultrasounds of their thyroid. We certainly should be checking their thyroid function in general, because although the direction has only been with medullary, we still don't know everything.
Yeah,
right?
They've not been around long enough. Yeah, that's good to know. I think you hear about these days. We hear about all the benefits, right? You know, obesity medicine. Physicians are pretty gung ho about it with the weight loss, but we hear very little about these side effects. So I think it's really important that folks know that this is a risk, and if you do have that family history, you do have that history of MEN too, that you let your doctor know and before you decide if you should start these meds. Yeah.
I'm curious about something.
Sure.
When the radioactive iodine.
Yes.
Is there any concerns with your family members when you are taking this, and how, do you want to keep them away from the kids or from a pregnant family member, et cetera?
Yeah, absolutely. So radioactive iodine management, I kind of think of it like, I don't know if you remember The Simpsons when Homer came home and he had like that iridescent green little thing that he was holding. It was bouncing all over the place. So like that's what I think of when I think of anything that's associated with radioactive. Because It is very true. So the way that it works is patients are basically iodine deprived for 2 weeks or 3 weeks before they get the treatment. And so in doing so, that allows any thyroid cells that might be residual to basically really thrive and hunger for the iodine. Then they take this iodine-laced pill, and it is easily absorbed into their body, but it's absorbed into all of the cells in their body that are utilizing iodine, including, of course, thyroid cells. So in this instance, we typically recommend that patients stay about 6 to 10 feet away from other people, their significant other, children, pets, and there are particular populations that we want to be completely out of earshot. So basically not in the same house, ideally. That's going to be children, it's going to be pregnant women, and it's small pets. So those are the 3 populations that really should be not in the vicinity of someone who is receiving this treatment within those 5 to 7 days. And I typically recommend that partners do not sleep in the same bed during this period.
Yeah.
I didn't know that.
Good stuff to know. What I like too is how each conversation we have, we could tie it back to our own specialties. Says OBGYN, you're like, the pregnant women, have that conversation. Yeah.
I think I get it more with an older family member, and they're concerned about their daughter or their niece, and should we get together for a family outing or our party, or should I just skip it?
Well, so in those situations where you certainly you can have some distance between you, I think that's completely fine. So right, the distance, we are maybe a little bit too close, but maybe like 6 feet apart, kind of like COVID days.
I was
Remember
thinking,
that?
yeah.
It should be fine. So that should be fine. And it's really just for 5 to 7 days. It's not that long.
That's
it
true.
seems like
Yeah.
it's forever, but it's really not that long, because it comes out through your sweat, through your urine, through your breath. So I think it's really important just to make sure that you have that distance just for that week. Sometimes I'll tell patients, go out of town, go on a nice little private vacation if you can afford to, so that you can just do your own thing, stay by yourself, and then your family, when you come back, hugs and kisses, everybody's fine.
Who knew social distancing was around with the head and neck surgeons long before COVID?
Long before.
Yeah.
Long before.
I could see being by myself for a little bit.
I know. We do.
If you had any sort of final words for our audience when it comes to their thyroid health, anything you'd like to impart?
Absolutely. I think thyroid health is so important, and understanding that you will be an advocate for your own care is, I think, the number one issue. If you feel something's off, then make sure you get it evaluated. Make sure that you get the blood work, ask for an ultrasound if need be. And I really think it's important to look for those constellation of symptoms. And so when we're talking about low thyroid function, obviously weight gain, like we mentioned, fatigue, hair loss, and for women, changes in their menstruation. And for hyperthyroid, it's typically the opposite symptoms. So patients are sweating, patients are losing weight. Oftentimes they have diarrhea. It can also lead to menstruation issues. So I think all of those are really important to just be aware of, so that you can be an advocate in your own care. Because oftentimes, especially for women, if we say, I'm gaining weight, I'm tired, I'm having trouble sleeping, they'll say, oh, you're just getting older, or maybe you're anxious. And sometimes these nonspecific symptoms can really be ignored by primary care providers. Not that primary care providers don't care, but that because they're so nonspecific, it's really hard to pinpoint what it is. And so I think it's just knowledge is power. So if you know something's wrong, if you feel off, ask for a test and see what it shows. And if it's normal, that means search for something else. But if it's abnormal, then that certainly can lead to an important and potentially life-saving diagnosis.
Well, thank you for that. Before we close, I'd just like to also have Dr. Teresa Rush introduce herself.
Oh, yes. My name is Teresa Rush. I'm an OBGYN. I've been in practice at Audubon Women's Medical for about 33, going on 34 years now.
And again, thank you so much, Dr. Wooten, head and neck surgeon. And this is the end of our segment today. The information shared on Healing with Her is intended for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your physician or other qualified healthcare professional with any questions you may have regarding your health. The views expressed by the hosts and guests are their own and do not necessarily reflect those of our institutions or employers. We hope you found the information enlightening and empowering today. Please subscribe to our podcast on YouTube, follow us and like us on Instagram and Facebook, and share with everyone you know. Thank you.